Welcome to part 2 of the autoimmunity videos. So what is tolerance? Well, looking at a standard definition or set of definitions that are germane to medicine in a typical dictionary, we find at least 3 separate definitions. One, and it's important, I think, to focus on these because these are definitions that patients will often have in mind. And if you use the word tolerance when talking to a patient, they may have a different definition in mind than you have. So the first definition is resistance to a poison or other noxious stimulus. For example, people say, I have a high tolerance to pain, or I have a low tolerance to pain. The second is the capacity to absorb a drug without adverse effect. And we sometimes refer to patients who've been on medications such as pain relievers for a long time that they have become tolerant to them. So for example, I was taking this pain medication and it worked great for a while, but now I've become tolerant and I need higher and higher doses, or I take large doses and it doesn't actually help me anymore. But the last 2 definitions are the ones that are really most relevant for us. And the first one refers to a lack of immunologic rejection of a tissue graft or transplant, and the most general one is unresponsiveness to an antigen that normally produces or elicits an immunologic reaction. Self-tolerance is the ability to recognize, respond to, and eliminate many foreign or non-self antigens while not reacting harmfully to one's own self-antigenic substances. And this should sound familiar because it harkens back to this self-non-self distinction that we talked about in contrast to the danger theory of immunity. In any event, immunologic unresponsiveness is also called tolerance, and a breakdown of that self-tolerance is at the root of autoimmunity. Tolerance to foreign antigens is what we hope to achieve when the immune system encounters things in the environment that are not dangerous, such as foods or inert substances, like when we breathe in cat dander or something like that. Those things are not intrinsically dangerous, and there's no reason for the immune system to perceive them as dangerous, so it ought not to attack those. It should literally just ignore them or kind of give them a pass, so to speak, so that they are not responded to with inflammation. Tolerance is generated in 2 ways. There's central tolerance to self-antigens, when T cells and B cells, these developing lymphocytes, encounter those antigens in the thymus for T cells and the bone marrow for B cells. Peripheral tolerance occurs outside of those generative organs in the peripheral tissues like lymph nodes, or the tissues of the liver, the lung, the gut, the skin, and those mature lymphocytes again encounter self-antigens, but they do not respond with inflammation. Now we'll move on to mechanisms of tolerance, and the key things to keep in mind are that autoreactive lymphocytes can suffer deletion, in which case they basically die or are killed. They can become anergic, in which case they still recognize but they do not respond to allergen or antigen, I should say. And lastly, clonal ignorance, where they don't even, so to speak, become aware of the material that they ought not to respond to. In terms of T cells, there's been a lot of focus on the research into a group called regulatory T cells, which is probably a pretty heterogeneous group of cells, because we don't really know how many different kinds of regulatory T cells there are. And B cells, it's important to remember, can initially kind of jiggle around their DNA, cut and paste it to recognize foreign antigens. But then if they encounter that antigen as they're developing in the bone marrow, they can get a strong signal through their B cell receptor and re-enter a stage of editing their DNA and kind of recombine components of the light chains, either kappa or lambda, if kappa fails, and generate a new VDJ recombination or complementarity determining region so that their antigen specificity changes. That's called B cell receptor editing. And lastly, it's important to remember that there are some compartments of the body that anatomically are called privileged. In this and the next few videos, we're going, and by that, I refer to areas like the brain, the eye, and the testes, where there seems to be some sequestration, so to speak, of antigen so that the immune system encounters those components less frequently, and therefore is less likely to respond to them with inflammation. This is just a diagram kind of illustrating that central tolerance, which occurs in the upper box, can lead to or can occur because that strongly stimulated lymphocytes die by apoptosis. The B cells can change their receptors, that's B cell receptor editing, or oftentimes T cells can become regulatory cells. In the periphery, these regulatory T cells can actually suppress other T cells or B cells, and other lymphocytes that are activated can become anergic or die by apoptosis. So in this slide, I just want to think with you for a minute about how positive selection and negative selection work and what can go wrong with them. Remember that positive selection occurs in the thymus, where T cells come in and they've rearranged their T cell receptor, and then the question is, do they recognize any self-peptide presented in self-MHC, all driven by this autoimmune regulatory gene called AIRE, A-I-R-E. In the case of positive selection, the immune system is saying to the T cell, listen, you better recognize self-peptide in the cleft of self-MHC in order to survive. Because if you can't recognize it at all, and there's no binding between the TCR and the self-peptide MHC complex, then that T cell is not really going to be useful because it cannot recognize anything, say, in the walls of the cleft of the MHC, and so it's not going to be useful. It's important to remember that those T cells are double positive. They have CD4 and CD8, and so they have a chance basically to recognize MHC class 1 or MHC class 2. They don't need to recognize both, they just need to recognize one. Negative selection also occurs in the thymus and occurs secondarily, and that's if the T cell that is developing does actually recognize self-peptide in self-MHC, but here it recognizes it too well. It binds so strongly by means of its TCR that it gets a big signal, and that suggests that that lymphocyte might be dangerous because it could induce an inflammatory reaction against self. And so T cells that bind too tightly are going to be deleted, that is, selected negatively. So what would result if positive selection completely failed? That is to say that nobody survived, no T cells survived positive selection. Well, in that case, all the T cells that are going into the thymus to develop would die, and there would be severe immune deficiency. What would result, on the other hand, if positive selection was complete and every T cell that went into the thymus passed and was told, you're great, you did well enough, you can go on? Well, then a lot of autoreactive T cells would survive. They would then go on to negative selection. What would result if negative selection completely failed? That is, there was no negative selection at all, right? Then all the T cells that had survived positive selection would just merrily waltz right through the thymus, and they would get out, and that would include a large number, a large segment of the population of T cells that are autoreactive, and they would get into the periphery and could potentially cause autoimmunity. But if negative selection was absolutely complete and every T cell that could recognize self-peptide and self-MHC was, kind of accused of being potentially autoimmune generating, then they would all be negatively selected. That is, they would all die, and then no T cell would survive, and there would again be severe combined immunodeficiency, a severe immune deficiency in which there was a susceptibility to infection. We'll stop here, and I will see you in the next video.